All right, so thank you, everyone. This is a calcium modification in a left main trifurcation where I upfront was planning to use MCS. Here are my disclosures. 63-year-old female, history of NASH. She was complicated by esophageal varices and cirrhosis. She's currently undergoing weekly paracenteses. She noted to her daughter that she was having progressive shortness of breath, and to the point that she was pretty limited in what she could do around the house even. Her daughter instinctually and good took her to the emergency room, and she was found to have an elevated troponin. And an echo was done while she was in the emergency room showing an EF of about 25-30%, so a diagnostic cath was ordered at that hospital. And you can kind of see already that there's some disease. So the outside shots are kind of limited, but you can see there's some haziness towards like the distal aspect of what the left main is, some mild disease then beyond in the circ, but really not seeing what's hiding behind here where the LAD is literally holding on by a thread. And then she has this lovely RCA CTO to kind of just combine everything for her. With that being said, she was sent to our hospital for surgical evaluation, but quickly declined from surgery as a result of the NASH and her overall long-term outcomes not being maybe so great at this point. Her medications were optimized, and then she was brought to our hospital for PCI. She did undergo MRI, which confirmed that actually all territories were viable. So with that being said, we brought her in, and I was fortunate she had good iliacs that were not tortuous, so I did the single technique Impella with a 7 French EBU 3.5, and it fit well. And this time I actually took a real caudal projection, which wasn't provided prior to the procedure. So a lot of my strategy I wasn't necessarily prepared for up front. I didn't realize that there was going to be this high OM branch that was there, or ramus, however you want to call it. But her prox LAD was certainly an issue, and then the circumflex had some haziness there too. So I opted to start with wiring both the LAD and the circumflex. And my kind of algorithm when it comes to calcium, if I can deliver a microcatheter or my imaging catheter, I'll probably be able to get IVL in there. If I can't, then I'll consider rotational atherectomy up front. After I had wired these two, I thought in my mind that maybe I should just protect that OM too, because it's still a decent amount of territory, and I don't want to lose anything for her knowing that she has that RCA CTO. So I did IVUS both of these. In the interest of time, you can believe me, and she had pretty good circumferential calcium as we get up to the more proximal vessel. So I decided to pre-dilate both vessels with 2.5 balloon, and I had limited expansion, but by IVUS distally, I was able to do a 3.0 millimeter shockwave into both the LAD and the circumflex, and got good expansion after that. With that being said, knowing that I had some disease in that high OM, but I wanted to avoid sort of trifurcation stenting, I decided just to do a cutting balloon for modification there, and then ultimately moved on to a 2-stent strategy for the left main and LAD and circumflex with DK crush. And I put a 3 by 38 in the left main and LAD, post-dilate that with a 3.0, and did a 3.0 24 in the circumflex system, and did proximal optimization with a 4.5 in the left main. And this is my final cranny and my final caudal, and before and after. So I think she got a decent result. With that being said, we were able to wean the Impella post-procedure. She actually did remarkably well hemodynamically throughout the duration of the procedure. She was discharged 2 days later. She was seen in clinic roughly 3 months after this with an EF improvement to 45, and symptomatically, she was back to kind of her normal routine. Her RCA CTO is still there. With that being said, certainly we all deal with calcium. Calcium is everybody's worst nightmare, but knowing to modify that ahead of time and using imaging up front is the key. The last thing you want to do is have stent regret and put in under-expanded stents, and I think all the information that we've kind of obtained from today is important that we think about what strategy we're using for patients, particularly females that have a lot of disease. With that being said, thank you.